Welcome to Mercy Medical Center's live webinar. Today we'll be discussing cancer survivorship. Joining us is Dr. Deborah Wilbur, medical oncologist with the Hall-Perrine Cancer Center. After discussion, she will take questions from our audience. To submit your questions anytime during the discussion, go to the window in the upper right-hand corner of your screen and type in your question. If you don't see the screen, click on the orange box with the white arrow. Your questions will be confidential. Well, welcome to our webinar, Dr. Wilbur. I am going to turn the mic over to you so we can get started.
Okay, the microphone's on and I'm hoping everyone can hear me. So this is entitled Cancer Survivorship, or Great, I've finished treatment, but now what? This is a really important topic. When people are actively undergoing treatment, they are being seen regularly by providers. There's a newness to it. Their friends, their families are supporting them, bringing them casseroles, praying for them. And then when they end treatment, when treatment is finished, suddenly there's this expectation that miraculously it will be as if it never happened, as if there hadn't been an illness. And suddenly people feel this pressure to return to who they were 100% immediately before this incredibly traumatic, involved experience. And so cancer survivorship as a movement nationwide has emerged as a very important topic of research and of clinical work because there is a huge unfilled need for this. Okay, so let me go ahead and advance the next slide here, and let's talk about the importance of survivorship and some demographic information. Currently in America, they estimate that by some counts, nearly 3.5% of Americans are cancer survivors. Other counts will say that there are 12 million cancer survivors in America, and that by the middle of this century that there will be 30 million cancer survivors living in America. The biggest population of cancer survivors are breast cancer survivors, and this is a testament to how far we've come with the treatment of breast cancer. In the mid-20th century, perhaps 2/3 of women diagnosed with breast cancer would be long-term survivors, but now 95% of women diagnosed with breast cancer can be expected to be alive 5 years after that diagnosis. Our second largest group of survivors at this time is the 2.4 million men who make up the prostate cancer survivor group. There are also over 1 million people currently living in America who are colorectal cancer survivors. And by some estimates, there are 500,000 of survivors of non-Hodgkin lymphomas. Now, in general, all comers, all types of cancers, 2/3 of cancer patients are alive at 5 years from diagnosis. So let's talk about what makes somebody a survivor. How do they define survivorship? So, survivorship, you're a survivor if you are in the process of living with cancer, through cancer, or living beyond cancer. So 1 second after somebody looks at you and says you have cancer, you are a survivor, and you will continue to be a survivor for the rest of your life. And I think this is a hard thing because sometimes people who are actively being diagnosed, actively undergoing treatment, or even those who have just finished treatment have a hard time looking at themselves as survivors, but they absolutely, unequivocally are survivors. Now, this next slide is kind of the way that the doctors in fancier talk define the same 3 phases. So they say this is acute phase, so living with the cancer phase. This is from the time of diagnosis as you're assembling your treatment team, as you're devising your treatment plan, and as you're beginning to undergo treatment. So that very, very initial phase. The next phase is the living through cancer phase, the extended phase. And this typically entails the end of treatment through the surveillance period until the physician and you are comfortable that it appears highly unlikely that the cancer will return. It also includes intermittent therapy. There are a number of cancer survivors now in whom cure is not possible, but long-term control is possible, and those patients often need to continue indefinitely with treatment or perhaps need to undergo treatment off and on for extended periods of time. The final phase of survival, and I think this is probably what we're going to spend most of our time on today, is the permanent season of survival, the beyond the cancer phase of survival. And this is from remission onward. And this is when we deal with long-term psychological and physical effects of the very often very rigorous treatment that has been given. So what does survivorship entail? What kind of topics, what kind of concerns do we need to look at when we're thinking about developing a personal survivorship plan for you? We need to think about physical issues. What kind of symptoms are you experiencing, will you continue to experience as a result of your prior cancer and of its treatment? There can be long-term sequelae from surgery, chemotherapy, radiation, hormonal therapy. Another huge topic is psychosocial concerns. Very often relationships change. Individuals struggle with overwhelming fears of recurrence, guilt. Also, the next item down is the economic issues of surviving cancer. It's often a very expensive proposition to undergo treatment for cancer. And furthermore, there can be a subtle bias that some people can have when they're cancer survivors, again, in the workplace, that can sometimes result in further lost income. The ability to get health care and follow-up treatment as appropriate is also a huge, huge issue in survivorship. We need to make sure that you as a survivor are empowered by information to know what it is that you need in terms of follow-up, what's appropriate, what's not, what's going to help you, what's not going to help you. And again, as previously mentioned, the late effects of treatment, and I believe that we might talk later a little bit about a newswoman who we've heard about some late effects of treatment about quite a bit in the news. And that plays into this second cancers. It is a sad but true fact that some of our treatments may predispose individuals to develop second cancers. There is also a truth that some individuals who develop one cancer just by the virtue of having developed one cancer may be at a higher risk of developing a second cancer. And then finally, quality of life overall. This is another issue that survivorship is very concerned with. We don't want people to just survive. We want them to thrive. And that is something that we absolutely have to deal with our survivors. And so kind of breaking this down into components of the different components, there are 4 major components that we look at. And we're going to go through these serially one by one. One of the first major topics is prevention. What can we do to prevent recurrence of the cancer that you have just successfully undergone treatment for? And what can we do to prevent second cancers? And what I'm going to go through now is information that comes from the American Cancer Society. And these are their recommendations for prevention for cancer survivors. And so in terms of exercise, the American Cancer Society is recommending quite a bit of it. So 150 minutes per week of moderate intensity activity. And so what is moderate intensity activity? That is defined as the amount of energy that it takes to walk briskly. So if you're taking a 30-minute walk 5 times a week, you should be walking fast enough, working hard enough that if your friend asks you a question, you should be able to give her a 1-sentence answer. You shouldn't be walking so slowly that you can just go on and on and on. Nor do you have to be walking so fast that you can just blurt out a yes or a no and nothing else. Along with the aerobic activity, the American Cancer Society is strongly recommending strength training twice a week for their cancer survivors. There are data that suggest that this may reduce the risk of cancer recurrence and may improve overall survival in breast, colorectal, prostate, and ovarian cancer. I believe that there are very strong data that support that regular exercise can improve quality of life, depression, and self-esteem in cancer patients. I've often had patients explain to me that developing a cancer felt like such a betrayal of their body, that they were just betrayed and that they just felt like they were living inside of something that they had no control over. And I've had many patients who have undergone an 8-week exercise program come back and say, I feel like I'm finally regaining control of this body, that I'm finally recognizing it as my own, that it's, that my body and I are part of the same team and we're working towards the same purpose again. And I would definitely feel that I can, from just personal observation, say that regular exercise has made a definite difference in people's quality of life and depression in my own practice. Now, I've talked about walking, but that's not the only option. Certainly people can bike rather than treadmill if they have bad neuropathy. Certainly people can swim. It's just a matter of doing whatever it is that you like, doing it consistently, and doing it with enough intensity that you're raising your heart rate and really getting that aerobic fitness. The next topic in terms of prevention that the American Cancer Society turns to in its guidelines for healthy survivorship is healthy weight maintenance. There are data that suggest that obesity may be associated with increased risk for cancer recurrences in multiple situations. And so strongly, cancer survivors are encouraged to do their best to maintain a healthy weight. And that is defined for young and middle-aged adults as a BMI of 18 to 25. And all you have to do is type in on your Google search BMI calculator, and it'll take you right to several good pages where you just have to type in your height and weight. Now, for people who are over 65, the BMI guidelines are a little bit more relaxed and are more along the lines of approximately 22 to 30. But for young and middle-aged adults, that BMI target on the screen of 18 to 25 is the recommended guideline. Our next recommendation is smoking cessation. This is single-handedly the most important change a cancer survivor can make to lower his or her risk of developing a different cancer in the future. Tobacco increases the risk of at least 15 different types of cancers. I think everybody knows about the risk of lung cancer, but I think they underestimate the contribution that tobacco plays in the development of pancreatic cancer, head and neck cancer, bladder cancer, and the list goes on and on and on. So the single most important thing as a cancer survivor you can do to lower your future cancer risk is to quit smoking if that's what you're doing right now. And now we talked about weight loss, but the American Cancer Society doesn't just stop on saying maintain a healthy weight. They actually really strongly hone in on the type of foods that we eat. So independent of weight, the kind of fuels we're putting into our body do matter. There are many studies, some that are positive for having an effect, some that are negative for having an effect, but the preponderance of the studies demonstrate that getting 2.5 cups of fruits and vegetables per day, decreasing saturated fat from red meats, and concentrating on whole grains appears to lower our risk of recurrence and possibly mortality in certain cancer risks. There are many studies out there, and you can find a positive one, you can find a negative one, but the American Cancer Society stance at this point is that when you take them as a whole, there are enough evidence to support that the type of fuels matter, that they strongly are recommending a high fruit and vegetable, low saturated fat diet. And so another way of saying that is concentrate on the foods you get from plants. Try to de-emphasize the amount of food you're getting from animals. Okay, so I think that covered my prevention. So let's move on to the second component. So we finished prevention and surveillance. So how do we look for spread or recurrence or the development of a second cancer? These recommendations come from ASCO. And ASCO is the American Society of Clinical Oncologists. And so this is the group of medical oncologists, and these are their national recommendations. Cancer survivors should have regular follow-up with whoever their cancer doctor is, and they also need to follow up regularly with their primary provider. Having had cancer does not protect you from developing diabetes or high cholesterol or high blood pressure. Very often I'm told, well, why do I need to go see my regular doctor? I see you all the time. Aren't you doing everything? And the reality is no, I'm really trying to make sure that cancer's not coming back. But really, as a cancer doctor, you really don't want me trying to do anything with your blood sugars or your cholesterol or your blood pressure. You still really need to see your primary provider. Also, the American Society of Clinical Oncology is strongly recommending that every cancer survivor receive and develop a survivorship care plan document. This is a document that you should be given as you end your active treatment that explains to you in writing, in black and white, when and how often you should have follow-up examinations. If and when you should have follow-up images. Oftentimes people, for example, breast cancer survivors who have undergone adjuvant chemotherapy for a earlier stage breast cancer are surprised to find out that they are not going to have regular CAT scans or regular PET scans or regular x-rays. But there are data that tell us that they don't find anything quicker or improve outcomes than just having regular follow-up appointments with their doctors and having patients feel empowered to call in between appointments if they develop any warning signs. And we'll talk about that in a minute. This survivorship care plan document should also include your risk of the cancer returning. Oftentimes, patients have no sense of how big the risk is or isn't. And I've seen this go both ways. I've seen people who had a very small cancer, who had undergone appropriate treatment, who had maybe a single-digit risk of their cancer coming back, but in their head, they thought it was far more likely than it was going to come back than it wasn't. And they were living under this incredible fear of something that was not nearly as risky as they had thought. On the other hand, I have seen people who were at extremely high risk of their cancer returning habitually no-show for appointments, not follow lifestyle recommendations, and when you finally have gotten a hold of them, been told, well, you did the treatment, so it's gone, so there's no way it's coming back, right? And so we have seen this both, and so I think real information, an actual number, or at least an actual estimation of a number of the cancer returning, can be very informative. The survivorship care plan document should also list warning signs you should look for. Most cancers have certain patterns of if they relapse in this place or in this manner with very, very typical symptoms. And so knowing, oh, I need to look for a cough that doesn't go away, or I need to look for lymph nodes that are swollen up in my neck, my armpits, my groin, that allows people to know what they need to be looking for, and so that they aren't worried about normal symptoms that develop from just life, and it empowers them so that they are educated and they know what to look for, they know when to call in, and they also know what to say, oh, well, that's just my sore back because it's always my sore back. So it's very empowering to know what the actual warning signs are so that you don't have to be afraid of everything. That survivorship care plan document should also have in writing recommendations for healthy behaviors, and those are pretty much the behaviors that we went over when we reviewed the American Cancer Society recommendations. The American Society of Clinical Oncologists has an excellent website that's called cancer.net, and on that website they have some examples of these treatment summaries. And this is one such, and it looks terrible on the slide, but just know that it includes the follow-up recommendations and then the risk assessments and the symptoms of recurrence that somebody should look for. And this one that I happen to pull from the sheet is for breast cancer patients. Okay, let's move on to the third component, intervention. Cancer and its treatment has many consequences, and these are some of the potential challenges following cancer and its treatment. Cardiovascular disease can be a sequelae of radiation to the chest. It can be a sequelae of some of the chemotherapeutic agents that we use. Cognitive dysfunction can result from radiation, can result from chemotherapy. I think there's a very real phenomenon of, quote, chemo brain, end quote, that you hear about among people who have been treated with chemotherapy. Reassuringly, long-term follow-up of chemotherapy patients suggests that the cognitive dysfunction is typically not severe on a permanent basis. There are also the risks of second cancers. Individuals who are diagnosed with one cancer just by having had one diagnosis of cancer are at a higher risk of developing a second cancer. Now, that's not a huge risk. I don't want you panicking out there, but that is a true statement. It is also a true statement that radiation and some chemotherapeutic agents are associated with the development later on of second cancers. That's really why radiation oncologists and medical oncologists wring their hands and really do a really thorough cost-benefit analysis before recommending their treatments, because we do know that this is a potential. Hypothyroidism can also result following radiation and with some of our newer chemotherapeutic medications. Dental problems. Dental problems can follow chemotherapy, can follow radiation if the mouth has become permanently dry. Insomnia, which is often related to anxiety about potential recurrence, can also be a very commonly heard concern of cancer survivors. Sexual dysfunction is another large area of concern for our survivors. Men who are on anti-hormonal therapy or men who are on hormonal therapy for prostate cancer, people who are status post who have undergone certain surgeries, women whose hormonal status has been affected by chemotherapy or aromatase inhibitors or tamoxifen can all have significant sexual dysfunction. For our younger patients, infertility or the risk of infertility can be a huge potential challenge. There are sperm banking that is widely available for men who are going to be undergoing treatment that might result in fertility. They're developing similar techniques for women for egg retrieval, but this is not nearly as widely available as sperm banking. Many women who undergo chemotherapy can undergo early menopause, and with that there seems to be more intense and more frequent hot flashes and an increased risk later on for bone loss. Lymphedema, which is swelling of an extremity, can result if lymph nodes are removed for a time of cancer surgery, for example with a melanoma surgery or with a breast surgery. It can actually also follow radiation to lymph node areas at times. Osteopenia is the fancy word for bone loss, and so this is the first step on the way to osteoporosis and can be an outcome of multiple of our medication treatments. Depression is people wrap their heads around what has been going on with their bodies and how their bodies are still feeling after the end of treatment is very common. Pain and fatigue are often very common following surgery, chemotherapy, radiation. And finally, peripheral neuropathy, which is numbness and tingling in the fingers and toes, is probably one of our top 5 most commonly mentioned challenges that survivors face as a result primarily of chemotherapies. And so how do we get past these symptoms now that I've had this exhaustive list? So, fitness programs. So getting into regular physical activity is very important. We're very fortunate here in Cedar Rapids that we do have a Thrive program that is a very successful program that Mercy offers, for example, where they have individuals meet 3 times a week with a trainer at the gym and really for 8 weeks get them into the habit of moving and exercising and being fit. Nutritional counseling, meeting with a nutritionist can be very, very helpful in terms of learning what the recommendations are, getting sample meal plans that are reasonably priced, even more importantly. We can do a great deal with physical therapy as well. Often if people are having difficulty with muscle loss, balance issues, there are even some data that suggests physical therapy can help with neuropathy. There are lymphedema specialists who can help teach massage, help fit patients with compressive gloves, compressive bandages, compressive sleeves to help with the lymphedema. Very often people can benefit from a short course of cognitive therapy with a psychologist, so some psychological counseling. I think pain management is also a very important part of cancer rehabilitation. I think patients have to be willing to let their doctor know that they're hurting, and they have to be willing to keep calling back if they're still in pain. Sometimes I think we're all too polite in the Midwest, and so we try one thing. Patients to let me know once that something's going on. I try something, and they just don't want to call back and bother me and let me know that it wasn't working. So you keep calling. You keep calling until your pain is managed. Very often we need to refer people to specialists outside of oncology or outside of primary care to deal with specific effects from their cancer treatment. So things like if there's a decreased heart function, we need to get you in with a cardiologist. Sometimes if counseling isn't enough, and we might need to send you to a psychiatrist briefly for help with depression medicines. And that brings me over to the next slide, part of the slide here. Sometimes we also do have to use medications for cancer survivors. Medications for depression, anxiety, insomnia, the hot flashes that sometimes come with early menopause, medications for bone loss. There are multiple medicines that we can try for nerve issues in the neuropathy. There are also patients who we need to prescribe pain medications for regularly as a result of their cancer treatment to be able to help them be functional. Finally, I think one of the biggest components of survivor care that we need to work on is coordinating care. And that is coordinating care between specialists, the oncologist, the radiation doctor, the surgeon, the medical oncologist, and your primary care providers. Cancer care is its own niche, and just as you don't want me, or just as I no longer really know how to manage diabetes, oftentimes primary care providers don't necessarily know what some of the long-term effects of cancer drugs, cancer radiation can be. And so we need to have excellent communication between you, your cancer doctor, and your regular doctor or care provider. And to help with that, just like as we talked about a treatment plan and follow-up, there's also treatment summaries. And that's a document that we give you as well. So we have two documents we're talking about here that lists when you were diagnosed, what kind of cancer you had, what kind of treatments you had, what the side effects of treatments that you did have already were, and also it needs to list the side effects of the treatment that could still develop in the future, so that if you come into your primary care provider 5 years from now with a symptom, that he'll think, well, you know, she did have that drug back when she was seeing Dr. So-and-so for that cancer. Maybe it's that. Let me think about that. And it also needs to have a nice list of just who all your healthcare providers are. Okay. And so I'm coming to the end of my talk here. I spoke too quickly. And let's talk about some resources. So www.cancer.net, that is the American Society of Clinical Oncologists website. And they have a very well-developed website that includes a very good survivorship piece for cancer survivors. www.cancer.org, that is the American Cancer Society's organization's website. They also have a very well-developed survivorship portion of their webpage. They also have a very good part of their webpage where you can look at for symptoms you're having and ideas on how to deal with it. The last one is www.cancer.gov. That is from the National Institutes of Health. The National Institutes of Health has a subdivision called the National Cancer Institute, and that is their webpage. What I like best about cancer.gov is that it has a browser into which you can type anything you want, but what they have is they have really good fact sheets, sheets about alternative medicines, herbal medicines, supplements, and you can type in that name typically, and they will typically take you to a pretty scientifically based fact sheet about that supplement, about that nutritional food, and it really kind of reviews what the data are. Very often when people are being treated or have been treated, you know, if I hear that their friends will come up, or a relative or a coworker will say, well, you need to be eating this herb, you need this berry, and and there are these attestations that it's the answer, but this web page actually has really good scientific data about what has been looked at and what is truly known. And so I do like that. It's a good, objective, reliable source of information. The other web page I have up there, the only one that doesn't start with www.cancer, is www.livestrong.org, and that's Lance Armstrong's organization. He's, of course, a very famous cancer survivor who has really been a very public face and force behind this move for survivorship care being recognized as being very vital. For too long, we said once the cancer was done, once the last drop of chemotherapy was in, once the last radiation treatment was given, good luck, you're on your own. And hopefully, as we've talked about here, you can see that we are continuing to work with you in an effort to try to restore you to as good of a quality of a life as possible. Okay, let's see what else is here. And so if there's, I'm going to take questions here in a little bit, but if you ever want any more information from me, that's my contact information. I work at the Hall-Perrine Cancer Center, and that's my number there, is 363-8303. And apparently I have a web page. Okay, here we go.
Well, thank you, Dr. Wilbur. Excellent information. And as you mentioned, we will go into the question-answer segment of the webinar right now. And again, just to remind you, your questions can be submitted from the box in the upper right-hand corner of your screen. And again, if you don't see the box, click on the little orange box, the little logo with the white arrow, and type in your question. Okay, our first question, Dr. Wilbur. I'm post-treatment and doing well, but I need advice about coping with the dread and worry I feel before each follow-up exam. Can you give any advice on this topic?
Well, I think I can give a little reassurance. Like I said, most cancers, when they come back, typically the individual is aware that something is going on and something is wrong. When you are done with your treatment, you need your last appointment before you go off for follow-up, you need to say to your doctor or your care provider, so what do I need to be looking for? What are the symptoms that to you would suggest that my cancer might be back? And so in terms of that, if you know what to look for, you're actually typically very right on if something is going on or not. It is actually uncommon for me to have a follow-up appointment with the patient and at the end of it say to them, I think something's going on, I think it might be back, and to blow the patient out of the water. Almost always there is a symptom going on that the patient has already identified. It is very rare to catch something that is asymptomatic. Most of the time the patient knows something's going on. So in terms of routine follow-up, routine scans, typically if you are feeling well, typically we don't find anything. Typically it's when you're having a symptom that you've been counseled to look for that has been persistent or worsening. That's often when we find something.
That's very reassuring to hear, Dr. Wilbur. Next question. You mentioned under economic issues that some people have issues in the workplace with lowered income. Can you explain what you mean or give examples of what you've seen related to this?
What I have seen is I have seen patients be told that they often feel that well-meaning coworkers continue to baby them for a long time and not let them take on more challenges, not let them do their work, and that they have then felt that they have been penalized for that. So what I have actually seen primarily are nothing where they're trying to push people out because of insurance concerns or anything like that. What I've seen is I've actually heard a fair amount of people say, I just need to have people let me be me and do my job, but they're not letting me. They're not letting me take on the extra project. They're not letting me take on, the extra hour because they're trying to help me. And I just know that my coworkers are know this and are doing this, but will my manager know this? And this is a very common theme that I've heard over and over again.
We have another question. Dr. Wilbur, are there any mentor or support groups in the area that you could recommend for survivors and or their families?
So yes, so the American Cancer Society here in town has multiple survivor groups. So I think if you wanted to contact the Cedar Rapids American Cancer Survivor chapter here in Cedar Rapids, that they do have several support groups. And they're not just here in Cedar Rapids. I think there's also a very active chapter, for example, out in Mount Vernon as well. They're in other areas as well. But I think the American Cancer Society is one organization that has really spearheaded support groups.
Another question. I'm just too embarrassed to ask my doctor questions about sex. Can my husband and I engage in sexual activity during his cancer treatments?
So that's actually a really common question. I'm going to punt a little bit and say that typically yes. The answer is typically yes, especially if the woman is the one receiving chemotherapy. Sex is almost always okay. In rare instances, when a man is receiving chemotherapy, there might be a few agents that you might want to talk to the doctor with first, but primarily, yes, sex is just fine.
Since my cancer treatment ended, I've had some pain during intercourse, yet the longer I go without having sex, the more I fear it. What can I do?
So I think communication here is key. I think if you're in a committed relationship with a partner, I think one of the things that you need to do is I think you need to really back off and really have a honest heart-to-heart. And oftentimes people need to kind of step back to almost back when they were first dating and really work on physical intimacy without sex, hugging, kissing, snuggling, cuddling. I think that you need to talk to your doctor about this. Vaginal dryness is extremely common in women after cancer treatments. There are very good lubricants that you can try. There's Astroglide, there's KY jelly, there's vaginal moisturizers such as Replens that can be tried long term. For people who did not have a hormonally based cancer, who are now having significant vaginal dryness and resulting pain with intercourse, you can also try a little vaginal estrogen as well, which often is very, very helpful. Okay, and so finally, I think also trying to fulfill your sexual needs and to obtain sexual gratifications through vaginal sex is also a very important option for people as well.
We have a question related to diet and exercise. If someone is doing the right things with exercise and diet, should they do anything additional to minimize bone loss? And does younger age change that advice?
So I think it's important, especially up here in the northern Midwest, where none of us get any sun, and so none of us have enough vitamin D. I think that in terms of bone strength, calcium plus vitamin D, a tablet of that twice a day is often a very reasonable recommendation for a woman. I think in terms of younger age, I think the younger you are, probably the stronger your bones are baseline going into this. So I think the regular physical exercise, the getting your calcium and your vitamin D, you're not smoking if you smoke. Smoking is bad for bone strength as well. I think I've probably beaten the smoking thing to death by now.
I don't think you can. It's an important message to get out there. I have another question about, you mentioned, just follow up with this one. What dosage is recommended as a follow-up?
I think usually if you get like an Oscal with D, it's just one tablet twice a day. It's the standard dose on it.
All right. So I saw that one come in and wanted to follow up. Okay. Related to Robin Roberts' diagnosis, someone asked, I've heard about that, her diagnosis with leukemia, and that it was probably caused by her treatment of breast cancer. I'm a breast cancer survivor. Should I be concerned?
So one of the drugs that is commonly used in the treatment of breast cancer is well known to later on potentially be associated with a second cancer, a leukemia. And that's usually, they estimate that around 1 in 1,000. It is very rare. Leukemia, unfortunately, typically when it develops pretty quickly, and people get pretty sick pretty quickly. And so I think if you're feeling well, I think it's almost, you don't have it. And so I think that is part of why you follow up with the doctor, is that we always check to make sure there are no signs or symptoms developing that would make us think, is this something that's going on? So.
Good advice. Listen to your body and keep that follow-up with your physician. Okay, another question from a breast cancer survivor. I am so tired, even though all my blood work and tests are good. What can I do to boost my energy level?
So I think that fatigue after cancer treatment is very common. A couple pieces to that. Sometimes fatigue can be an early sign of depression. And so I want to make sure, I would want to always make sure that people are not depressed. I want to make sure that people are sleeping and they are not having insomnia that we need to address. In terms of if those factors aren't present, then I really think that what we work on is we work on good sleep hygiene, going to bed at the same time at night, getting up at the same time, not taking naps. We work on regular physical activity and make sure you're exercising regularly, and eating healthy fuels, and so good food. And so those are the things we talk about with fatigue. Fatigue is the #1 concern of patients when they walk into a cancer doctor's office, whether they're undergoing treatment or if they're survivors. It is the #1 in national studies concern that people have. It's hard.
Another question, will soy protect me from breast cancer, or should I avoid it? And what about flaxseed?
Okay, so the soy story goes back and forth and back and forth. There are small studies that say it's protective. There are small studies that say if you start eating soy as an adult, it might actually increase your risk of breast cancer. The real answer is on huge meta-analyses when they have looked at all the studies and all the information that's available on soy. It's actually a wash. So it is a safe food to eat in regular quantities. I don't think it's going to help you necessarily. I don't think it's going to hurt you. I think it's a good low cholesterol source of protein. So I think in terms of breast cancer, it's pretty much a wash. Flaxseed, there are some data on flaxseed, primarily in animals, that suggest it might prevent prostate cancer. I believe there might be some data that's very weak data, perhaps in colon cancer. I don't think it's well known at all to have any protective effect in breast cancer prevention. Again, this is another time for me to plug the NCI website, the cancer.gov website, where, again, you can just in their search bar basically type in any sort of supplement, any sort of herbal like this, and they usually will give you a really good fact sheet about what is truly known and what is truly not known about whether or not that agent can help prevent, treat, cure an illness.
And just to remind people that a tape of this program will be available on this same website, www.mercycare.org/live. So if you missed those websites, you can go back and check later. And this webinar will be available in just a few days. You'll be able to access it. And then you can always check this website for information about future webinars and, again, listen to the past. Our next webinar topic is domestic violence with Elizabeth Hoffman. She is a nurse practitioner at the Mercy Employee Health Center. Her webinar will be Thursday, July 14th. I believe I might have a typo on the screen. It is the Thursday. I'll check that here in just a minute. And she will take your questions live after the webinar. Okay. Thursday is the 12th, so excuse me, my notes were wrong. The screen is correct. I believe we have covered all questions submitted to us today, but if you have additional questions and concerns, Dr. Wilbur can be reached at the number on the screen, 319-363-8303. Thank you all for joining us today.